So I was the PI, the principal investigator for this trial, where we did an early phase testing, what we call phase 1 and 2 testing of a combination of a novel tyrosine kinase inhibitor, a targeted therapy called sitravatinib, in combination with the immunotherapy nivolumab. And one of the unique aspects of our trial was that it actually tested simultaneously at the same patient both the toxicity and the efficacy. So it was both a phase 1 and a phase 2 at the same time. And the goal was to determine whether those two drugs can be combined, and if so, what is the best dose based on both side effects, toxicity, and the efficacy of the drug in clear cell kidney cancer, which is the most common type of kidney cancer. So we have thus far enrolled actually 42 patients. The data cutoff that I'm going to present is from January 1st, 2020, and at that time we had toxicity data from 40 patients and efficacy data from 38 patients. So that is what I'm going to present on Saturday. We found that the combination is certainly something that can happen, so the combination is feasible and it does have efficacy. So when we compared with historical data from giving nivolumab alone in the same patient population, you would get a response rate on the range of 25%. By adding sitravatinib to nivolumab, we can increase that response rate from up to 39 or 40%. And similarly, with regards to the progression-free survival, the time until a patient has the disease growing and progressing, it potentially more than doubles that. So the way we measure response rate is by doing imaging, and when I mention response rate, I mean confirmed response with at least 2 consecutive images. So a patient would have to have their cancer shrink based on their RECIST criteria, the established RECIST criteria, and after seeing that once, that there is, a partial response or a complete response, that would have to be confirmed by a subsequent image at least 1 month apart from the first one. So the toxicity profile was a little bit distinct from what you would expect with other tyrosine kinase inhibitors of its kind. So with sitravatinib, we saw quite a bit of diarrhea. Not immune-mediated diarrhea, though, interestingly, but diarrhea nonetheless. But we saw much less hypertension. We usually see with these kinds of drugs high blood pressure, hypertension. We didn't see as much with this drug, and we didn't see as much hand-foot syndrome. And that is with regards to the side effects that were directly mediated by the sitravatinib. The other one that we would see more commonly with sitravatinib than with other drugs would be the increase in amylase and lipase. These are enzymes produced by the pancreas. Rarely this would progress to pancreatitis. That would be clinically significant, but that is also another more distinct feature of the sitravatinib compared with other TKIs. With regards to the more immune-related side effects, again, I do find it interesting that we're really not seeing immune-mediated colitis with this combination, but we may be seeing a signal that there may be other types of immune-related side effects that we're seeing, potentially like pneumonitis, for example. So this is definitely an interesting combination. The hypothesis behind the combination was that drug, sitravatinib, will change the immune microenvironment in ways that would be beneficial, but while it is doing that, it could potentially create avenues through which unique side effects can occur, and so we're very sensitive to make sure we monitor that as the trial progresses. So based on the dose that we felt on this trial is the the best dose with regards to efficacy and toxicity, and that is 120 milligrams of sitravatinib given daily. Another trial opened in urothelial cancer, mainly bladder cancer. And actually that trial was a little bit different now in the sense that it would enroll patients who had actually had disease progression on immune checkpoint therapy, like nivolumab. So they would have progression on those drugs, and now you would add sitravatinib to nivolumab, and we were seeing responses, and we actually presented the response data in the SITC conference last fall. So that was one of the next things that we did. In addition, there is now testing of this combination of sitravatinib with nivolumab or other anti-PD-1 immune checkpoint inhibitors in other disease sites.